Thank you so much, Dr. Tityal, for having me in this course and also for those kind words. This is the topic allotted to me today, subluxated cataract. These are my financial disclosures. I've received travel support from some of these companies, not relevant to the subject matter of my presentation in this particular session. I'm just going to take you through 4 videos of subluxated cataracts, different situations and the way I've handled them. Maybe there could be some relevant take-home messages. This was a case of Marfan's with, you can see that the patient was about 6 years old. So I decided to go ahead with the removal of the lens as well as implant an intraocular lens. And that's a high molecular weight viscoelastic going in. One of the challenges, like in pediatric cataracts, in subluxated cataract, is get a good adequate rhexis. And I always do this corneal marking. This 5 millimeter mark which leaves 5.5 millimeters on the surface, and usually I slightly decenter the mark when I'm dealing with a subluxated cataract, for the simple reason that you have to keep in mind what's going to be the anatomical position of the intraocular lens once the bag is recentered. And with a well-inflated bag with a cohesive viscoelastic, I go through the side port and create an adequate rhexis. In this case, because the zonules are reasonably intact, this seems to be quite easy to do. And then subsequently, not an excessive hydrodissection, but an adequate hydrodissection. Never rotate a subluxated cataract, because whatever little zonular support is there, that could be damaged. And in these young patients, usually what you need is just phacoaspiration. Of course, in some cases, you can just do it off with a irrigation aspiration. But because of the larger port that it offers, then I prefer doing a phacoaspiration. Keep the parameters very low. The bottle height also should be just adequate, and essentially you have to clean up the cortex subsequently, and that's again, I always prefer a bimanual irrigation aspiration. In my hands it gives much better control, and with almost every quadrant of the lens capsule being accessible. I don't routinely polish the back of the anterior capsule, but in the case of a pediatric cataract, especially in subluxated cataracts, because of the propensity for the lens, for the capsule to shrink, I routinely go ahead and polish the back of the anterior capsule. As you could see, there are fibers which are getting removed, and it's extremely important that the moment I fill in this viscoelastic, you can see the subluxation almost disappear. Of course, this is a more straightforward case, and all it requires is an endocapsular ring. Having said that, Marfan's is a progressive zonulopathy, and I have come across situations where years after the primary implantation of intraocular lens, this tends to subluxate. And please see that I'm using a second instrument, a Sinskey hook, to support the endocapsular ring while I'm introducing that. That ensures that the endocapsular ring, part of it at least, does not go into the angle of the anterior chamber, when retrieval becomes a bit of a problem. When you're going to implant the lens in the bag, if your choice is a single piece intraocular lens, you can stick on to that. And as you can see, I position the haptics also in such a direction as to offer an extra support over the in the area of subluxation, so that in addition to the endocapsular ring, it offers an adequate support. Going on to our next scenario, this is a simpler case, a 55-year-old male patient, and as you can see, the subluxation is quite obvious over here. And here again, the challenge for me when I'm dealing with not the extreme subluxation, but these kind of milder subluxations, the main challenge is to get an adequate capsular rhexis, and going through the side port, keeping the anterior chamber well inflated, using a cohesive viscoelastic, and not hesitating to refill as and when required are important tips that you could follow. And having a well dilated pupil like this is also an important advantage. Of course, you could, because of the laxity of the zonules and the tendency for the lens to rotate, though in this case I'm going to be introducing the capsule retractors a little later. I could have introduced the capsule retractors over here even before the rhexis is completed, and that gives the lens a lot more stability and so much more control even during the process of the capsular rhexis. And as you can see, there is a tendency for the rexus to run off to the periphery. So I take my time doing this. Sometimes 30 to 40% of the time for doing the entire surgery is taken up in just doing an adequate rexus, but I think it's time well spent. And that's almost the completion of the rexus. There is a little runoff to the periphery, but as I recenter the lens, this should become more centrally located. I go ahead and inflate a exchange with the capsular rexus forceps, complete the rexus, and as you could see, essentially I'm seated temporally and doing the surgery, so it's essentially nasally the lens is subluxated temporally and you can see the gap nasally. So I just use two iris retractors. In these cases they are iris retractors, but nowadays the capsular retractors are also available, which are more specifically made for retracting the capsule. They are a little wider, the tips are a little more rounded, and that gives a more adequate support to the capsular fornices. Once these are in place, there seems to be so much control to the entire surgery. That's endocapsular ring being injected using endocapsular ring injector, and this you can go through the side port, but if I'm using doing it with the forceps, I tend to go through the as in the previous case, through the side port and then go ahead and place the endocapsular ring. And here again, one thing I observed, not that it never happens, but most often when it's a subluxated lens, it's also a softer cataract. Perhaps you do not have to face both the problems of a very hard cataract and a subluxated lens together. So I do not mind getting the lens out of the bag as soon as there is a tendency to prolapse. Of course, might be slightly deleterious to the endothelium, but once you are doing the removal of the nucleus in the anterior capsule, there's less chances of disrupting the whatever little support is there for the capsule. And gentle removal of the cortical matter is done. Of course, with the endocapsular ring in place, it's a bit more of a challenge. That's the reason that in the previous case where there was better support, I removed the entire lens matter before placing the endocapsular ring. But in this case, I have placed the endocapsular ring. Instead of pulling the cortical matter towards the center, you gently tease it off tangentially. And the lens that goes in is a aspheric lens with zero aberration, and whenever there is a Q value of 0, whenever there is a tendency for the lens to tilt, this might be a good lens to implant, though this is not the lens that I commonly use. It's for the simple reason that once decentration occurs, which can occur in spite of your best surgery, there is always a tendency for the asphericity to function in a wrong way if there is a significant amount of asperity in the lens that you implant. And in a case like this, a more extreme case where we need to not only support the bag, but you also have to recenter the bag, is a more extreme case of decentration. And in this case, I'm going to use a Sionis ring. Basically, my preferred way of doing a capsular rexus is to go through the side port using a bent 26 gauge needle. But whenever there is a need, I do not mind exchanging with a capsular rexus forceps. The idea is to get an adequate rexus and again observing the principle of keeping the AC well formed. And you have to be quite careful to make sure that you do not disrupt whatever little support is there. In this case, as you can see, I am not going in with a phaco probe. Because of the more extreme subluxation, I want the procedure to be more gentler. So I evacuate whatever material is there, the lens material, with just using irrigation aspiration. You fix the Sionis ring nearer to the area of maximum subluxation. That's why you saw the triangular flap being made over there. Then that's you have Sionis ring with double eyelet, single eyelet. This one with a single eyelet. Essentially, this has to be brought in close approximation to this area. And you do not have an injector for this, so it has to go through a main port. I had threaded already a 90 Prolene needle through this, tied up the needle, and sometimes 10-0 could also be used, but there is a greater tendency for that to break, and this gives you a little better control. As you can see, as I introduce this Sionis ring, the position of the eyelet comes away from where I want it to be, so I gently rotate the ring in such a manner so as to bring it in approximation with the area of maximal subluxation, where I also created this scleral flap. by using the railroading technique, which we are all familiar with while doing a scleral fixation of the intraocular lens. I essentially thread the straight needle through this 26 gauge needle and then tie the sclera. Basically go through the episclera and tie it up, and you can see as I tighten the suture, there is a tendency for the capsular bag to settle down in place. And here I am using a 3-piece lens. You could also use a single-piece lens and implant it within the bag. So this is the post-operative picture. You can see that even through an undilated pupil, you do see that eyelet of the ring over here. But otherwise, with the dilated pupil, you can see that the lens seems to be reasonably well centered. I think I have another 1.5 minutes. I'll just run through this last video of mine. This is a case, again, highly subluxated, pediatric subluxated cataract. Not everybody would agree with the way I managed this case. I do find that in these situations, sometimes it's better to remove the lens with the back in toto and then go ahead and just do iris clip lens or a glued IOL or a scleral fixation of an intraocular lens. As you can see, I am able to get a reasonably good rhexis even in this situation. But right in the beginning, because this lens was highly subluxated, the preoperative examination, it showed that the patient was 8 years old, and it showed that the lens was highly tremulous. So I decided not to try to fix this back, but try to just evacuate the lens completely and then fix an implant, in this case an iris clip lens. And I'm going ahead and removing the lens material, and then subsequently I'd be using a vitrector to just remove the capsule. I'm sure Dr. Abhay will not agree with this line of management, but this worked well. It's not that we have had a wide experience with this. Basically, we have been using iris clip lenses for the last 4 years or so for adult secondary implants, and just a few seconds. That's the vitrectomy being done and the anterior capsule being removed, and then subsequently just introducing the adequate anterior vitrectomy is done. This is a planar iris clip lens that goes into the anterior chamber, and it goes in the vertical meridian. Then you usually just rotate it to bring it in the horizontal meridian. We were using the very sized lenses earlier, but gave it up because of the progressive endothelial cell loss. So we have these specific enclavating needles available, enclavating forceps available. So just gently tuck one of the haptics under the iris, create an iris enclavation, go behind on the other side and enclavate the other haptic also between the pincer-like haptics. Enough amount of iris tissue has to go in. You have to make sure it's quite stable, and that's end of surgery. And this is what you see in the post-operative day, slightly horizontal ovalization of the pupil. This is with the pupil slightly dilated, while this is the normal eye taken a week later. Thank you so much for your attention.